My name is Barbara Albertson. I am from the University of Washington Medical Center in Seattle. This is session 314, Answering the Call to Action. I want to introduce our speaker. Dr. Carol DeBello is an assistant professor at Columbia University School of Nursing in New York, where she teaches courses on public health, care coordination, and palliative care. She is board certified as both a family nurse practitioner and as an advanced certified hospice and palliative nurse. She's also a certified Train the Trainer for the End-of-Life Nursing Education Consortium, also known as ELNEC, and has been involved with palliative care for over 15 years. Dr. DeBello has practiced in a variety of settings, including nursing homes, hospitals, medical offices, and inpatient homes. She was the initial provider and later associate director of what became a large palliative care management program at the Visiting Nurse Service of New York. There she trained and managed interdisciplinary teams responsible for patients across all 5 boroughs of New York City. She has served as a participant in the Greater New York Hospital Association Palliative Care Collaborative and was a member of the board of directors for the Westchester End of Life Coalition. So please join me in welcoming Dr. Carol DeBello.
Everybody, can you hear me? Great. So I do teach at Columbia, and normally context is everything, right? To understand who's in the audience and who you're teaching. So I teach, when I teach the care coordination class, I usually have at least 200 students in the classroom. I'm not really good at standing behind the podium, so you will see me grabbing my notes and making sure that I'm telling you everything that I need to tell you. I like to have discussion, which is why it's nice for everybody to sort of be involved. I'd also like to know who's in the room. Who teaches in a university setting? Anybody here teach in a university? Okay, great. Do you have palliative care or care coordination in your curriculum already? Anybody? Okay, great. Love to talk to you guys. Who amongst you cares for patients now and has been trained in palliative care? Anybody? So ELNEC? Okay. Anybody else done ELNEC before? Okay, it's a great program. How long? Where do you do it?
Oregon Health Science, or where did I do the training?
No, where do you do the ELNEC? And are you're a Train the Trainer? Is okay.
I did that training in Boise, Idaho.
Oh, okay.
Teach at Oregon Health Science University.
Oh, great. So, and what about someone back here was also done ELNEC? What is your experience with ELNEC?
I just went to the conference to have more experience.
Teaching.
And now I'm actually the supportive care nurse outpatient.
Okay. And of the people who have been ELNEC trained, any of you are actively involved in a care coordination or a CCTM program right now?
I'm a partnership liaison nurse grant that is workforce development for care for primary care.
Oh, good. Okay. So that helps me. I mean, I sort of developed this presentation I know what I do, and I'm just telling you what I do, but I wanted to make sure that it was broad enough to meet everyone's needs. So that helps me a lot to understand who's in the room. So the care management program that I did run at VNS, when I first started, I was the lone nurse practitioner and the manager of the program. Over the course of years, and before they closed the program, for reasons unrelated to our program, more organizational, we had 550 patients across the 5 boroughs of New York that we were managing the palliative care needs of these patients. It was a great program. We did some great stuff. And so I'm really enthusiastic about integrating care coordination and palliative care together. I think it's a really perfect match, and I'd like to show that to you today. So what I'm going to do is introduce the calls to action. There were several calls to action by the American Nursing Association that led us at Columbia to incorporate both care coordination and palliative care into the curriculum. We're going to discuss the connection between care coordination and palliative care. They're the very same patients. All the care patients who need care coordination are also patients who need palliative care. I'm going to describe a little bit about the ELNEC, the End of Life Nursing Education Consortium, and why this has been chosen as the curriculum for primary palliative care education. I'm going to review the development of the course that I teach at Columbia, and it's a pre-licensure program, so context is everything. The students that I teach are, it's an accelerated program of 15 months. So the students come in and we have had physicians from other countries come into the program. So the students, I keep saying patients, students can either have had a bachelor's degree in something else. They could have had a master's and some of them a doctorate. One of our current students they range widely in age. We have very young students, but one of our current students actually studied with Margaret Mead many years ago, and also danced and was trained by Martha Graham. So she's a little bit older, and she's wonderful. So I'm also going to talk about education techniques, because this is a challenge for all of us. And when you have so many people in a room and they all have their own worlds, and so those amongst you that teach in universities, these millennials are different, aren't they? Can you remember when you went to nursing school, would you have ever missed a single class? First of all, I was paying for it. Why was I going to miss a class? These students feel as though attendance is just sort of, maybe I'll go or maybe I won't go. So engaging them in the material and helping them understand how important this is really quite a challenge. So actually, I did not include a slide, but you should know that I have nothing to disclose. So the first call to action was in 2012. The American Nursing Association suggested that care coordination should be an explicit component of pre-licensure as well as master's and doctoral nursing education and scholarship. So nurses have been doing this all along, but now they're asking us explicitly to educate our nurses before they get out into the field about the concepts of care coordination and what all is involved. So heeding that call in 2015 is when I actually started teaching care coordination at Columbia. The care coordination is sort of threaded through the whole curriculum. It's in Med-Surg, it's in OB-GYN and Peds, Psych. It's in the community and public health class that I teach. But at the end of the 15-month program, they have a whole semester of care coordination. And I teach that class. And within that care coordination class, I've embedded the ELNEC curriculum. In 2017, not that long ago, the ANA, in collaboration with the Hospice and Palliative Nurses Association, put out another call to action for all nurses to get primary palliative care training. And so we are the people that are on the field, on the ground with patients. We're there when they're really sick. We're there when they're dying. And yet, in our curricula, there has not been a lot of palliative care or primary palliative care training. So we're expected to take care of these patients as the same way we're expected to provide care coordination, just by figuring it out as we go along. How many of you guys had to figure out how to do care coordination as you went along? Right? No one taught you how to do it. You just I don't know how to fix this. Let me just see what I can do. Right? So both the ANA in both of these calls to action said we need to train our nurses, pre-licensure nurses, how to do care coordination and how to do palliative care. So the ANA says that palliative nursing is the essence of all nursing care. We provide palliative care all the time, but we may not have had exact training in it. We're the ones holding the hands of the people who are dying and that are really sick and helping their families. So how many of you, though, when you think of palliative care, think only of end-of-life care? Yeah. So, and that's very common amongst healthcare providers and families. We were just talking earlier, a lot of people feel as though that when a patient goes on to hospice, that actually the causative factor of death was the fact that they went on to hospice. How many of you have heard that before? That I don't want to go on to hospice because then I'm going to die. So no big surprise here, but in fact, there was a great article in The Onion many years ago that actually showed a bar graph of all these different countries, and all the bars were the same all the way across. And the caption read, "The world death rate is holding steady at 100%. So, and I'm sorry, every once in a while, palliative care people have really peculiar senses of humor. But palliative care, we all at one point in our lives will take care of a patient who has palliative care needs. And I would say, yeah.
I found it interesting, and I was delighted during the last session as far as population health, and then we had the discussion about the opioid crisis.
Mm-hmm.
And someone that got up to the microphone mentioned this patient we needed to refer to, or some of the patients with chronic pain need to be referred to palliative.
Did you hear me go, woohoo, in the background? Yeah, there are, patients are not referred to palliative care in a timely way. And it's a lot of it, at least in my experience, sorry about that, at least in my experience, it's not because patients and families don't want it, it's because healthcare providers don't understand what palliative care is, what it provides. They really feel like it's giving up. The worst thing that I've ever heard in my life is when a physician says, "There's nothing more that I can do for you." There's actually lots and lots you can do for the patient. It may not be disease-directed therapy, but there's actually lots and lots that you can do for patients at the end of life. So let's look at the palliative care continuum for a second. Has anybody seen anything that looks like this before? So palliative care continuum is actually a very long continuum. There are certain illnesses that the recommendations are for palliative care to be initiated at the point of diagnosis. It doesn't happen all the time, and there are reimbursement and other reasons why this doesn't happen, but it should be started at the point of diagnosis. So if you think about, there are a couple of things I'd like to ask you to think about. If you think about a patient that goes to the doctor's office and says, I think I have cancer, is that what they do? They usually say, I have this symptom, I'm not sure what it is. So palliative care is about managing symptoms. So if they're having symptoms already and that's how they have come to be diagnosed, they actually have palliative care needs from the get-go. Palliative care can't be provided at the same time as disease-directed therapy. So I had the great pleasure of working in an oncology clinic where I was the palliative care provider, and I was partnered with oncologists who we actually managed the patients together. And I managed their palliative care needs, and they managed, the oncologic needs. And that can be a really long period of time. I've had cancer patients who have graduated from their oncology and graduated from my services and gone on to live long and healthy lives. So palliative care is really not a death knell. It's about taking care of patients' needs. Hospice is the Medicare-defined benefit of 6 months. So Medicare has defined this benefit, and what they say is you have to meet certain eligibility requirements in terms of how your disease is progressing, but most specifically, you need 2 physicians who will sign off and say that if your disease were to follow its normal trajectory, that you will probably die within 6 months. And there's nothing written in stone that you have to die within 6 months, but this is best guess that if you were to follow your normal trajectory, that you would die in 6 months. And the final part of this trajectory, or this continuum, is bereavement services. And I think this is one of the best things about hospice care that is not part of usually of a palliative care service, is that following the 13 months following the death of a loved one, hospices offer chaplaincy, palliative bereavement specialists, social workers who can help the loved ones of someone who has just died for up to 13 months. And the reason why they do 13 months is that's usually the time period where you go through some like anniversaries, and to help the person go through those anniversaries in a meaningful way. Had anybody seen this continuum before? Yeah. So, because I asked students to do this, I thought I would do this for you as well. I